We often think of estrogen as like the ultimate fix for menopausal changes, right?
Oh, absolutely. That's the standard assumption.
Yeah, the idea is that once your hormones start fluctuating, simply replacing them is going to solve every single downstream issue.
Right. But what if treating these intimacy issues isn't solely a hormonal problem? What if it's actually a structural one?
Exactly. And that brings us to the core mission of today's deep dive. We are looking at this really fascinating trend in modern cosmetic gynecology.
It's a huge shift in how we approach this.
It really is. We're tackling a highly specific question today, one that you might actually be researching yourself right now. And that is, can localized topical estrogen therapy be continued concurrently with a G-spot hyaluronic acid filler?
It's such a great question because, it bridges two completely different approaches to medicine.
Totally.
On one side, we have biological repair, and on the other, you've got this immediate mechanical volume. And understanding how they interact, well, it requires looking at the actual cellular environment of the vaginal wall.
Which is exactly what we're going to do. And just to give you an overview of the sources we're unpacking today, it is quite the stack.
We really pulled from everywhere for this one.
We did. We've got the 2024 Jafarzad randomized controlled trial, the Esalane study, and clinical trial data from platforms like Power.
Right. Plus expert clinic guidelines.
Yeah, exactly. From specialists like Boston Pelvic PT and Dr. Shemaya Bassi. We are even looking at the practical realities of managing these treatments at home.
Down to the plastic applicators, actually.
Down to an eBay listing for disposable applicators, which, trust me, is way more interesting than it sounds.
Oh, it's crucial.
But, okay, to make sense of all of this, I think we need to establish a baseline. Before we even talk about combining treatments, I mean, if your body is a garden, is using estrogen and an HA filler at the same time, like using fertilizer and a sprinkler concurrently?
That's a great analogy.
Or are they just gonna, flood the lawn?
Well, the short answer is a resounding yes. They can be combined. They actually make a fantastic team.
Awesome. But the why and the how is really the fascinating part, right?
Absolutely. Because when a patient decides they need something as advanced as a G-spot HA filler, we have to look at what is actually happening in the tissue to prompt that in the first place.
Right. What's the underlying issue?
Generally, it's what we call genitourinary syndrome of menopause. You'll hear it called GSM.
Okay.
In some of the older literature, you might see it referred to as vulvovaginal atrophy. Basically, as systemic estradiol levels decline, the architecture of the vaginal epithelium completely changes.
And this decline, that can be from perimenopause, menopause, or even postpartum changes.
Exactly. Any of those can trigger it. And the tissue actually loses its rugae.
Rugae.
Yeah, they're these natural folds that allow for expansion. And the epithelial lining physically thins out. It shifts from this robust, multi-layered structure to just a few really thin layers of basal cells.
Oh, wow. And I assume that thinning is what translates to the physical symptoms women actually experience.
Yes, exactly. The chronic dryness, the friction, the loss of physical sensation.
Because the blood flow is decreasing too.
Dramatically. With less vascularity, the body's natural production of hyaluronic acid drops. So the tissue loses its structural cushioning entirely.
So it's literally just thinner and less padded.
Right. Which is why the first line of defense is usually localized topical estrogen.
Okay, let's break down the mechanism there. We know estrogen is the biological fix, but how is a localized cream actually changing that thinning tissue?
So when you apply a topical estradiol cream directly to the mucosa, it binds to estrogen receptors in those basal layers.
Okay.
It acts as a signaling molecule. It effectively tells the cells to wake up and resume their normal metabolic functions.
Like it flips a switch back on?
Exactly. And that stimulates angiogenesis,
Which is?
the formation of new blood vessels. So
Yay.
it's bringing nutrient-rich blood back to the area. And it also signals the fibroblasts to start synthesizing fresh collagen and elastin.
Wow. Okay, so it is fundamentally rebuilding the biological structure from the ground up. It's like the cellular architect.
That's a perfect way to put it. Now, it takes time, often weeks or months to see the full histological shift. But yes, it thickens the lining and restores the biological foundation of the tissue over time.
Okay, so if estrogen is doing all that heavy lifting at the cellular level to rebuild the foundation, where does a hyaluronic acid filler even fit in?
Right, because HA is completely different.
Yeah, I mean, I know HA is a humectant that holds water. Anyone who uses a face serum knows how hyaluronic acid works on the skin.
Oh, for sure.
But how does its molecular structure behave differently when we are talking about injecting it into the highly vascular mucosa of the vaginal wall?
That is the critical distinction here. So a face serum uses what we call uncross-linked HA.
Okay.
Imagine them like loose individual strands of spaghetti. If you inject uncross-linked HA into the body, enzymes called hyaluronidases will just snip those strands apart.
Oh, they just metabolize it immediately.
Yeah, the entire thing would be gone in a matter of days. It wouldn't last at all.
Uh,
So for a procedure like G-spot amplification, physicians use a cross-linked HA filler.
Cross-linked. Got it. And the sources mention a specific product, right? Cereal Plus,
Yes, Cereal Plus, which is CE marked.
which just means it has passed European regulatory safety standards specifically for this kind of mucosal application, right?
Right, exactly. And that cross-linking process we just mentioned is what makes it viable as a filler.
How does that work?
Well, in the lab, chemists use a binding agent to create chemical bridges between those individual HA strands.
Oh, so they are tangling the spaghetti together.
Exactly, turning it into this dense three-dimensional mesh. And because the molecules are bound together so tightly, the body's natural enzymes take, 4 to 6 months to chew through that mesh.
Which is what gives us the longevity of the actual treatment.
Exactly.
So walk me through the actual procedure. According to Dr. Bassey's clinical notes from our sources, the G spot, the Greffenberg spot, is located on the interior wall, right? Like about 5 to 6 centimeters inside.
That's correct. And as the surrounding tissues thin out due to that atrophy we talked about, that specific highly innervated area loses its prominence.
It just flattens out.
Yeah, physically flattens, which leads directly to a loss of physical sensitivity. So the procedure itself is an outpatient non-surgical intervention.
Okay.
The physician applies a topical anesthetic and then injects about 3 to 5 milliliters of this dense cross-link HA gel directly beneath the mucosa in that specific spot.
Wow. And because it's a humectant mesh, it just immediately draws in water and holds it right there.
Right. It acts entirely mechanically. It does not bind to hormone receptors at all.
Right.
It simply provides this immediate localized structural volume and mechanical cushioning. It pushes that innervated tissue outward so it regains its prominence.
Okay, wait. I want to push back on this for a second because I'm looking at this Jafarzad data here.
Okay, let's look at it.
This was a 2024 randomized controlled trial. They had 300 patients dealing with vulvovaginal atrophy. Half of them received vaginal estrogen, and the other half received vaginal hyaluronic acid.
Yeah, it's a really fascinating data set because of how clearly it isolates those variables.
Right. And the results showed that both treatments were highly effective on their own. Like the vaginal health index scores improved significantly across the board for both groups.
He did.
But the nuance was that HA was statistically superior for treating localized itching, while estrogen was statistically superior for treating overall dryness.
Right.
So if they both work so well on their own to restore the tissue index, aren't we just double charging a patient for the same clinical outcome?
The fair question.
Like, isn't it kind of redundant to use a daily estrogen cream alongside an expensive cross-linked HA filler?
Looking at the raw outcome scores in that study, it is really easy to assume they are redundant.
Yeah.
But if we go back to the mechanisms we just discussed, combining them creates an incredibly powerful synergy.
Really? How so? Connect the dots for me here.
They're not doing the same thing at all. Estrogen is biological,
Mm-hmm.
HA is mechanical.
Okay.
Let's use your analogy of a house. The topical estrogen is pouring a solid concrete foundation.
Right. The cellular architect.
Exactly. It is repairing the structural integrity of the walls, ensuring the blood flow is adequate, thickening the mucosa.
Yeah.
But pouring a foundation doesn't give you a place to sit today.
Oh, I see.
The cross-linked HA filler is the beautiful plush furniture you put inside that house. It provides immediate, targeted volume, intense mechanical hydration, and instant physical sensitivity in a localized area.
Oh, I love that. So you can have the biological foundation without the structural furniture, but having both creates a significantly better living experience.
Exactly. And the medical community is actively investigating this dual approach right now.
I saw that in the sources.
Yeah, our sources highlight an upcoming 2026 clinical trial by a platform called Power. They are actively testing this exact protocol,
Layering them.
layering vaginal estrogen therapy with an HA treatment. They want to prove that the combination offers superior symptomatic relief for GSM compared to using estrogen in isolation.
So they want the hard clinical data to prove that the foundation plus the furniture objectively outperforms just the foundation alone.
Exactly. And there is also a secondary, highly practical benefit to this synergy, which was noted by the women's health platform Alloy.
What's that?
Well, because topical estrogen rebuilds the underlying collagen matrix and the natural springiness of the tissue over time, Maintaining that estrogen regimen can actually reduce a patient's dependency on the injectable filler.
Wait, really? How does rebuilding the collagen reduce the need for the HA gel?
It comes down to the structural integrity of the extracellular matrix. If a doctor injects HA into tissue that is severely atrophied and, paper thin, they need a larger volume of filler.
Oh, so they need the full 5 milliliters just to get any projection.
Right, because the tissue simply cannot support itself. But if the tissue is already thickened, vascularized, and fortified by estrogen, it possesses its own natural volume and scaffolding.
Ah, so when the physician goes in to perform the G-spot amplification, they might only need 2 or 3 milliliters of the HA to get the exact same result?
Exactly. Or, and this is great for the patient, they find they can stretch the time between appointments.
Because it's not degrading as fast.
Or just that the loss of prominence is less noticeable. If the cross-linked HA is sitting in a robust, estrogen-supported cellular environment, a 4-month cycle might easily stretch to 6 or 8 months.
Wow, that bridges the aesthetic intervention beautifully with long-term foundational cellular health.
It really does.
But, okay, this brings us to the logistics. Because the biology makes total sense, the synergy makes sense.
Sure.
But how does a patient practically manage applying a topical hormonal cream at home while they're also recovering from an HA injection in their vaginal wall?
Yes, this is where the theoretical science meets the reality of patient compliance and hygiene.
The messy part.
Exactly.
Oh.
When you introduce a needle into the mucosa to deposit filler, you are creating a puncture wound. So infection control becomes the absolute priority.
Which perfectly explains why our source stack includes an eBay listing for a 20-piece set of disposable plastic vaginal applicators.
Right.
Because at first glance, looking at the specs of, low-density polyethylene plastic and threaded ends, it seemed a bit mundane for a deep dive into tissue biology.
It seems random, yeah.
But it's actually about mitigating infection risk.
It is entirely about infection control. See, when managing a prescription compound, like an estradiol cream formulated by a pharmacy, patients often use a reusable applicator that they just wash out between doses.
Right, but if you've just had a G-shot, washing a plastic tube in your bathroom sink is not going to cut it.
Absolutely not. Reusable applicators, no matter how well you scrub them, can harbor microscopic bacteria.
And introducing any bacteria near a healing HA injection site sounds terrible.
It's very dangerous because of how bacteria interact with implants. They can form what is known as a biofilm.
Oh, I've heard of that. Break down what a biofilm is mechanically for us.
So a biofilm is this slimy, protective extracellular matrix that bacteria build around themselves when they attach to a foreign surface.
In this case, the HA gel.
Exactly. And once bacteria encase themselves in a biofilm, they are incredibly difficult to eradicate.
Can't you just take antibiotics?
Systemic antibiotics often cannot penetrate the film at all. So the only solution is usually to completely dissolve or surgically remove the HA filler.
Oh, wow. So spending like $14 on a pack of sterile, single-use disposable applicators with exact dosage lines is essentially an insurance policy for a very expensive clinical procedure.
Exactly. You apply the estrogen, throw the plastic away, and guarantee you aren't introducing a pathogen to the healing site.
Because the mechanics of how the medication is delivered are just as vital as the active ingredients themselves.
You've got it.
Okay, so the at-home hygiene is handled, but let's talk about the actual timeline. Can a patient use their estrogen applicator on a Tuesday night and walk into the clinic for a G-shot on a Wednesday morning?
Clinically, no. This is a crucial medical caveat.
Okay.
While the dual therapy is highly synergistic in the long term, timing around the actual day of the procedure requires a strict pause.
A pause on the estrogen.
Yes. If we look at the clinical trial parameters for HA injections, specifically trial NCT 0421972, their exclusion criteria mandated that patients halt local vaginal estrogen therapies for 1 full week prior to receiving the HA injection.
Wait, why require a 1-week washout period if the estrogen is making the tissue healthier?
Because of the angiogenesis we discussed earlier.
Oh, the blood vessels.
Exactly. Estrogen dramatically increases localized blood flow. While that vascularity is excellent for long-term health, a highly vascularized mucosa bleeds significantly more when punctured by a needle.
Oh, that makes sense. So you want the tissue to be in a calm baseline state.
Right. To minimize the risk of excessive bleeding, hematomas, and acute inflammation during the injection process.
Okay, calm the tissue down before the trauma of the injection. Are there any other contraindications that would stop a clinic from performing the procedure?
Well, the standard dermal filler rules apply here. Providers will not perform the injection if there is an active viral infection like herpes or a bacterial or fungal infection like thrush.
Which circles right back to why we avoid biofilms.
Exactly. Also, patients with a history of hypertrophic scarring, where the immune system overreacts and forms thick, raised scars, they're excluded too.
Got it. I also noticed in Dr. Taffery's clinic guidelines from Los Angeles that patients are specifically instructed to avoid NSAIDs like ibuprofen, aspirin, or naproxen in the days leading up to the session.
Yes, and the mechanism there is platelet aggregation.
Okay, explain that.
When a blood vessel is damaged by a needle, platelets in your blood stick together. They aggregate to form a clot and stop the bleeding.
Right.
NSAIDs work by blocking CAW-X enzymes, which unfortunately also prevents the production of thromboxane A2, and that is a lipid that platelets need to stick together.
So NSAIDs effectively thin the blood, and in a highly vascular area like the anterior vaginal wall, compromised platelet aggregation means severe bruising?
Exactly. Avoiding NSAIDs ensures the body can effectively seal those micropunctures immediately.
All right, so the patient pauses the estrogen, avoids the ibuprofen, and the 15-minute procedure is successful. What does the immediate aftermath look like? If the goal of G-spot amplification is to enhance physical intimacy, how soon can the patient actually benefit from it?
Well, it requires some patience.
I figured.
The injected area will be tender and likely swollen as the tissue accommodates all that new volume. Guidelines from the London Cosmetic Clinic advise avoiding any activities that put direct mechanical pressure on the anterior wall,
Like what?
like cycling or horseback riding, for several days.
That seems like common sense, honestly.
Right. They also strongly recommend avoiding damp, warm environments for up to 10 days. So no Turkish baths, hot tubs, or swimming pools.
To ensure the puncture wound fully seals without bacterial intrusion.
Yes, exactly. And as for resuming intimacy, while some aggressive estimates suggest a few hours, the consensus among conservative cosmetic gynecologists is to wait up to 5 days.
5 days, okay.
It allows the cross-linked HA to properly integrate with the surrounding extracellular matrix, and for the acute swelling to completely subside.
Okay, so we've established how it works when it goes perfectly, but what happens when it doesn't? Like, if we're talking about injecting a dense chemical mesh into highly sensitive tissue, what are the actual risks?
Beyond transient swelling or slight bleeding, the primary risks involve how the body reacts to the gel itself. One risk is the formation of granulomas.
Granulomas.
Yes, this happens when the patient's immune system identifies the cross-linked HA as a foreign invader. It can't easily break down. So instead of absorbing it, the immune system walls it off with white blood cells, creating this hard, inflamed nodule.
Oh, that sounds incredibly uncomfortable in that specific anatomical location.
It is. Another risk is the Tyndall effect.
Right.
If the physician injects the HA gel too superficially, like too close to the surface of the mucosa, it alters how light passes through the tissue. HA is a clear gel, but because of how it scatters short-wavelength blue light back to the eye, the tissue above the filler can take on a distinct, bruised-looking bluish tint.
Oh, wow. But this brings us to the ultimate safety net of hyaluronic acid, right? And quite frankly, the reason it dominates the aesthetic filler market.
A reversal, yes.
If a patient develops a granuloma or the Tyndall effect, or if they simply decide they hate the sensation of the amplified tissue, they are not stuck with it for 6 months.
They are absolutely not. The procedure is entirely reversible using an enzyme called hyaluronidase.
Explain how that reversal mechanism actually works.
Well, we mentioned earlier that cross-linking binds the HA strands together so the body's natural enzymes can't break them down easily. Hyaluronidase is a concentrated injectable form of that exact enzyme.
Oh, I see.
When a physician injects it directly into the unwanted filler, it rapidly cleaves the glycosidic bonds holding the HA mesh together. It essentially uncross-links the gel.
It turns that dense 3D mesh back into loose spaghetti.
Precisely. And once those bonds are broken, the gel liquefies. And the body's lymphatic system just absorbs and flushes the hyaluronic acid away, often within 24 to 48 hours.
That is amazing. Having that enzymatic undo button drastically lowers the barrier to entry for patients considering such a sensitive procedure.
It really gives them the biological freedom to try a structural solution without a permanent commitment.
So, bringing this all back to the core question that kicked off this deep dive. Can you continue localized estrogen therapy concurrently with a G-spot HA filler?
The answer is a resounding, scientifically backed yes.
Yes. Because they operate on entirely different mechanical pathways. The localized estrogen handles the biological, cellular repair,
Thickening the tissue, rebuilding the collagen foundation, and increasing vascularity.
while the HA filler handles the structural, mechanical side.
providing immediate localized volume and enhanced sensitivity.
So as long as you manage the logistics, pausing the estrogen a week before the injection to control bleeding, avoiding NSAIDs, and using sterile disposable applicators to prevent biofilm infections, these two treatments form a highly effective dual approach.
They do. It represents the absolute cutting edge of personalized regenerative women's health.
It really does.
But, you know, synthesizing all these sources actually leaves us with one highly provocative question regarding the future of this dual therapy.
Oh, what is the unanswered question here?
So we established that cross-linked HA fillers eventually degrade over 4 to 6 months, right?
Right.
Due to a combination of natural enzymatic action and mechanical stress. The friction of daily life slowly wears down the gel. But if a patient is rigorously maintaining their topical estrogen therapy, they're actively creating a thicker, more hydrated, more robust extracellular matrix.
The tissue surrounding the filler is just biologically stronger?
Exactly. So the question is, does that robust estrogen-fortified cellular environment act as a protective shock absorber for the HA implant?
Oh, wow.
Right. Could the continuous application of topical estrogen reduce the mechanical friction on the gel and thereby slow its degradation?
That is fascinating.
We might find that by optimizing the baseline cellular health with hormones, we can significantly extend the chemical lifespan of these aesthetic fillers well beyond the standard 6-month window.
Imagine doubling the lifespan of a structural filler simply by maintaining the biological health of the tissue housing it.
Is a fascinating frontier for women's health that bridges aesthetics and cellular biology, and one that future clinical trials will undoubtedly explore.
It's a brilliant concept to leave you with today. Thank you for joining us on this deep dive. Keep questioning the science, keep exploring the mechanisms behind the medicine, and remember, the most effective solutions often come from understanding how the different layers of our biology interact.